Okay, hello everybody. Today we are going to have a very uh, short but very substantial review for antibiotics. My name is Dr. G, so please we are going to start right now. Alright, so let's start directly over the group of antibiotics that is our interest. Number one is having three groups. It's important to remember that we have three groups of antibiotics. One is that it inhibit the protein production to repair the wall of the bacteria, so the bacteria eventually will die. Beta-lactam is like a big weapon where the antibiotic is literally drilling from outside the wall of the bacteria, destroying the bacteria. And the nucleic acid inhibitor is the one who is blocking the DNA of the bacteria, inhibiting the transcription and the translation to produce proteins. Remember, proteins, what are those? Those are the bricks, let's put it this way, the bricks of the wall of the bacteria. If you don't have bricks to be able to repair and maintain that wall, the wall of the bacteria eventually, the wall will decay and rupture, right? So the bacteria will die. So we have the three mechanisms. All right, so talking about that, we have three of these medications that are going to work in the similar way. Aminoglucosides, tetracyclines, and macrolides. So for aminoglucosides, the prototype that we need to remember is the gentamicin. And the tetracycline, again, this is easier. The prototype is called tetracycline. Macrolides are going to be the erythromycin, is the prototype. So we have, and don't confuse this mycin with Y-cin, that is macrolide. Aminoglucosides are going to be gram-negative. Tetracyclines are going to be broad spectrum. What does it mean? It's going to be positive and negative, and macrolides again is going to be a broad spectrum, positive and negative. All right, so let's start with the first antibiotic, and is our aminoglucosides. Aminoglucosides, the prototype is going to be, as we said already, is the gentamicin, right? The gentamicin. So this gentamicin is for gram-negative, and what we are going to use for are going to be for UTIs. What is the most common UTI? Is coming from the E. coli. All right, the most common, I said, because it can be gram-positive sometimes, but E. coli is the most common. Meningitis, wound infections, especially anaerobics, and gram-negative, and septicemia, that is an advanced infection. All right, so EUTI. Let's stay with UTI and gram-negative. That's what I want you to remember so far. All right, so the side effects of the gentamicin are going to be the ototoxicity, and nephrotoxicity. We are going to see that at the end of this review, we are going to have 5 antibiotics who are nephrotoxic. We are going to find that there is 2 antibiotics that are ototoxic. I will tell you, ototoxicity is going to be the aminoglucosides, and the prototype is the gentamicin and the vancomycin. Those are the ones who produce ototoxicity. In the nephrotoxicity, we are going to see in the time, but we have actually the aminoglucosides. Let's put it this: aminoglucosides, the vanco. So vanco are the same with the ototoxicity, but here nephrotoxicity can be penicillin, cephalosporin, and the quinolone. All right, so aminoglucosides, ototoxicity and nephrotoxicity. You need to always think about, and please review, what are the nursing considerations for ototoxicity and what is for nephrotoxicity. All right, first of all, recognize the early stages of ototoxicity. You can have tinnitus, that is the ringing of the ear, and it could be something that is field that is blocking the ear that you not can hear, even you don't hear any sound or lower sounds. That means that something's wrong with the ear. So how to recognize that? You need to speak louder in order to the patient understand. Nephrotoxicity, we are going to see the lab test, right? The lab test, the Chem7, where we have the creatinine, and BUN, blood urea natrium, right? Okay, so ototoxicity is the cranial nerve number 8, the vestibulocochlear, okay? Fullness in the ears. So that is not a sound, that is not the ring, but that is considered damage of the cranial nerve number 8 too, okay? So that is about. So one more thing that we need to remember is that they have problems with the muscles, Gentamicin, problems with the muscles. They're going to block the cholinergic receptors in the muscle. Cholinergic receptors in the muscle. So that means that you are going to feel weakness. And myasthenia gravis is one of the contraindications. Myasthenia gravis is an autoimmune disease that is going to destroy the cholinergic receptors. Right? If you going to give aminoglucosides in myasthenia gravis, is going to make it worse. So just remember, we have ototoxicity, nephrotoxicity, and muscular dysfunction. Okay. Another thing we need to remember: gentamicin is incompatible with the heparin in the same syringe. No same syringe. Number one, no same syringe. If you're going to give it at the same time, or you want to try to give it, you give it in different area. For example, gentamicin intramuscular, or could be IV. Intramuscular, you need to wait about 1 hour in order to give the gentamicin. Otherwise, they are going to precipitate. So they are going to link to each other. Okay, so that is about. So here we have one thing that I want you to remember. The aminoglucosides in the general practice we are going to have, they are going to mix with penicillin. And penicillin is a beta-lactam. Okay. They can be used with cephalosporins. Cephalosporins is to a beta-lactam. Okay, beta-lactam. Beta-lactam is a ring that is going to have in the structure of the antibiotic. For example, penicillin and cephalosporin, they have the ring. And this is actually drilling the wall of the bacteria, penicillin. So, conclusion here, aminoglucosides is gram-negative, penicillin is gram-positive, gram-negative, and they are going to produce what we call the synergism. Very common to use, aminoglucosides and penicillin. So gentamicin and penicillin, gentamicin and cephalosporin, like cefalexin, cephalotin, etc. Okay, so here we have that the loop diuretics, and this is important, can lead into tinnitus. Loop diuretics, of course, is not what? It's not antibiotic, it's a diuretic. And when they are giving gentamicin plus loop, is high risk for ototoxicity, period. Okay, so let's keep going. So that is about aminoglucosides. Aminoglucosides, again, gram-negative, is going to be nephro, could be auto, and can be muscular weakness, right? So that is, don't mix with heparin, no heparin, okay? All right, so let's go over another one, the tetracycline. Tetracycline is, what is the prototype? Is the tetracycline, simple. And everything, that all the words, and I don't want you to remember short, intermediate, long acting, it's just to show you something here, that the suffix, cycling, like a bicycling, like bicycle, like bicycling. That is a tetracycline. Okay, tetracycline. All right. So here we have they are going to have again some nursing considerations that I'm going to go on the next slide. One thing is that mostly all antibiotics that we are going to mention, they have nausea, vomiting, and some diarrhea. So those are the three bigs, right? In addition to that, for example, we have gentamicin is a nephrotoxic, neuromuscular damage, and ototoxicity, right? So we already saw that. Tetracycline, in this case, please, no children. If you have a kid less than 8 years old, don't give tetracycline, please. Don't give tetracycline. Why? Because the teeth are going to become like this. Okay? So can you see this decoloration of the teeth? So that is going to be permanent. So don't give tetracycline to kids of 8 years old or less. Okay? Another thing that we need to remember is the photosensitivity. Photosensitivity, for this we have a mnemonic. Here we have not too much sun. Okay, don't do too much sun. Okay, T, M, and S. T is the tetracycline, can produce photosensitivity. Macrolides are going to give you the prototype, erythromycin. That is going to be a macrolide, produce photosensitivity. And S-SAN is the sulfas, okay? All right, so tetracycline are going to be used for example, atypical pneumonias. So that is, there is many other things, Vibrio cholera, whatever. They are going to use some type of other diarrheas are going to use tetracycline, but the one that I want you to remember is that mostly do atypical pneumonias. Atypical pneumonia. What is atypical pneumonia? Because the typical pneumonia is done by the pneumococcal, that is a gram-positive. And guess what? Pneumococcal is the other name of the streptococcal. That is the pneumococcal. That is the one who produces most commonly the pneumonias. Okay? And atypical are going to be other bacteria that are not the pneumococcal or streptococcal. So that's why tetracycline is going to be for atypical pneumonias. For example, we have the Citrobacter, we have the Klebsiella. Klebsiella is very common. Klebsiella is actually used tetracycline. So pneumonias, tetracycline, atypical pneumonias. Aminoglycosides, UTIs. Let's keep going. So remember here the photosensitivity side effect for these three medications. So tetracycline is going to be for atypical pneumonias. Macrolides, erythromycin is going to be for the skin and respiratory tract infections. And sulfas are for UTIs, mostly commonly used. Okay, all right. So that is not too much sun, so produce photosensitivity. Not too much food. We have TMF, tetracycline, macrolides, and fluoroquinolones. Fluoroquinolones are the same to say quinolones. Okay, so no problem with that. All right, so not too much sun, not too much food. Okay, so what it's going to do is to decrease the absorption of the antibiotic. All right, so let's keep going to the macrolides. So we already talked about aminoglycosides. What you need to ask yourself is the spectrum. What is the spectrum? What is the use? How is the use? The most common use. The most common use for this antibiotic. Side effects, okay, and side effects. So at the end, you're going to talk your nursing considerations. If you have photosensitivity, what you need to do, right? So if it's going to be, for example, blockers, okay, and half an hour before to be exposed to the sun and not go out between 10 to 3 o'clock where the sun is going to have the highest radiation of UV. Okay, so let's keep going. So macrolides, the prototype, as we already talked, erythromycin. So what is the first question? Spectrum. Spectrum, what it is, macrolides, positive and negative. So it's broad spectrum. What is the next question? The most common use, respiratory and skin problems. Next question, side effects. The side effects are going to be, again, macrolides, photosensitivity, right? If one question here is that the macrolides are not used with the statins. One thing is important, statins. Statins are going to decrease, is the HMCO reductase inhibitor, right? Remember, are the statins. So the Lipitor and all these guys. So they are going to increase the muscle breakdown. So be careful with the statins and erythromycin. So what is the most common use? Respiratory and skin infections, right? Okay, so we have the penicillin. Why I mention penicillin here? Because here is the second choice. So if you are allergic to penicillin, don't use penicillin. You're not going to use cephalosporin either. Why? Because cephalosporin and penicillin belongs to the same family that we are going to see in the next slides. So they can have cross reaction. So if penicillin is having, the patient is having allergies of penicillin, you're going to have actually a 10% chance to have a cross reaction with if you give the cephalosporin. What is going to happen? It's going to have allergic reaction. They can lead what? In anaphylaxis, yes, and death of the patient. So if you have, you're going to ask very careful to the patient. So the patient is the first time never received penicillin. So how do you know they can have an allergic reaction? There is some clues you can ask in the clinical history. Number one is the patient is having some type of allergies, any type of allergies, fish, shellfish, or latex, or whatever other gluten allergy, whatever they have, that could be giving you a clue. The skin tests are not conclusive. They are going to take their hand and put a small scratch in the skin and put some amount of the antibiotic, but this is not completely reliable. Why? Because if that give you a skin reaction, a strong skin reaction, yes, okay, is a positive reaction, so you don't give the medication. But if there is no skin reaction, that is not going to exclude that the patient or it's not going to rule out that the patient is allergic to penicillin, so it's not 100%. Okay, so after penicillin and cephalosporin, the second choice is going to be the macrolides. So number one, penicillin. If you cannot use that, you're going to use macrolides. Erythromycin, mycin. But look like it's gentamicin, right? Aminoglucoside. No, because you have the rho here. Romycin. That is romycin. Okay? The gentamicin is gentamicin, streptomycin. Okay? So they are not going to the amikacin. We have tobramycin. So we have many of the others in the aminoglucoside, and they don't have Rho. So Rho is macrolide. Okay? All right, so let's keep going. We have the next one is, if you see here, we have the protein inhibitor. We already, what we had? We have the aminoglucosides. We have the tetracycline, and we have the macrolides, right? Macrolide. So we have three in the protein inhibitor. In the beta-lactam, so this is fade, now this is light, that is what is coming. Beta-lactam, we have penicillins and we have cephalosporins. Penicillins and cephalosporins. These guys, what they are going to have is this ring. Can you see this ring on the top? This beta-lactam ring. So this beta-lactam ring is going to be in the penicillins, in the cephalosporins. Monobactam, we are not going to see this time. So penicillins and cephalosporins, beta-lactam. What they are going to do is to drill, they are going to drill the wall of the bacteria. So that is the tool. So we have penicillin, and for this we have three groups of penicillin. Number one, we have the beta-lactamase sensitive. We have the extended spectrum, okay? Aminopenicillins, and we have the beta-lactamase resistance, okay? All right, so these and these are coming together, but I want just you figure out three groups. Beta-lactamase sensitive. So listen, this is the beta-lactam. This is the antibiotic. Antibiotic is going to send the beta-lactam to kill the bacteria, to drill the wall of the bacteria. But the bacteria, this is the bacteria is being killed by the beta-lactam, in other words, the penicillin, right? But the bacteria start to produce one weapon that is going to stop the action of the beta-lactam. It's going to be called, this is the bacteria, and the bacteria is going to produce the beta-lactamase, ACE enzyme. So the beta-lactamase of the bacteria that is going to destroy the beta-lactam antibiotic, and the antibiotic is not going to make effect. So that's why we have beta-lactamase sensitive. That means that if you give antibiotic to, for example, staphylococcus that produce beta-lactamase, this antibiotic is going to be just water. It's not going to make any effect on the bacteria. So beta-lactamase sensitives, if we are talking about the antibiotic, the beta-lactamase sensitive means the antibiotic is sensitive to this enzyme produced for the bacteria, the beta-lactamase. The opposite of that, on the other side, we have the beta-lactamase resistance. So these antibiotics are going to doesn't pay attention to the beta-lactamase from the bacteria. They are going to still killing the bacteria no matter what is having, if the bacteria is having the beta-lactamase. Okay, so let's go to the groups. And we have one of the things I want you to remember. We have this the beta-lactamase sensitive. These are the very beginning of the antibiotic therapy history in the world. We have penicillin G, we have procaine sodium, penicillin B with potassium, and benzatinic that's coming with potassium too. So we have penicillin G sodic, procaine sodic, K and K. So in these penicillins, first of all, we are not used for staphylococcus that are resistant to the who produce beta-lactamase. Is the bacteria produce beta-lactamase? The most common are the staphylococcus are going to they are not going to make any effect. So they are not going to do anything. Side effects of the beta-lactamase sensitive. I give you a clue already. So we have injections. The mostly are intramuscular. This is intramuscular. IV. Benzatinic is only intramuscular. Procainic is intramuscular IV. And the penicillin B is intramuscular too. And what happened here is that you're giving with sodium, with potassium, and potassium. So what could be a side effect? It's going to be what? Kalemia, hypernatremia. So signs and symptoms of hyperkalemia and hyper. So electrolyte imbalance. Okay? Electrolyte imbalance. All right. So let's keep going. So here we have just a moment. Okay, so I need to, because the looks like audio is failing because other things are open. So I'm going to initiate again. Okay, so if you see here we have the penicillin G sodic, and they are going to have a lot of sodium there. So if you're giving a lot of sodium there, what you're going to have is hypernatremia. So that's why, because they're giving with the penicillin. Here we have the penicillin B potassium tablets, potassium tablets. So they're going to be hyperkalemia. You got it? All right, so here we have the different, mostly these penicillins nowadays, they are going to use, for example, in OB, obstetrics, and they are going to use for prophylaxis. Prophylaxis. Prophylaxis means is the prevention of the infection. Okay, they don't have the infection yet, but they are going to prevent. Okay, so then we have the gram extended, and we have the amoxicillin. You are very familiar, and the ampicillin. Amoxicillin is a broad spectrum, as you see, gram positive, gram. So mostly penicillins are broad spectrum, positive and negative. Let's remember that penicillins are given with aminoglucosides, produce that synergism. Okay. All right. So amoxicillin is still sensitive to the beta-lactamase of the bacteria. So they are going to add the clavulonate potassium. Oh, potassium. Okay. It can tell you something here. Potassium. So clavulonate potassium is going to inhibit the action of the beta-lactamase of the bacteria. So the bacteria, even though that is going to produce beta-lactamase, this amoxicillin plus this is going to stop the enzyme of the bacteria, and the bacteria will be killed. Side effects, hyperkalemia, because you are giving potassium, right? Hyperkalemia. All right, so we have and the very common is the augmentin. You will hear that very common in everywhere. Amoxicillin and clavulonate. Amoxicillin, before they was giving actually ampicillin, amoxicillin for dental procedures, for example. But nowadays they look like it's changing for the quinolones that we are going to see later. So you know, we are in permanent fight between the mutations of the bacteria that become resistant with the new medication that already exists. All right, so we have here this in this group of amoxi and ampi. All right, so here we have, for example, we have amoxigenta. So that is one combination. You can have ampigenta, genta ampi. So they call by short ampigenta when they give ampicillin and gentamicin. Remember the penicillins are going to produce synergism with the gentamicin. Okay, all right. Carbenicillin and picarcillin, just names, please. I want you to remember that is going to be used for gram negative, gram negative, gram negative. And that is used for the pseudomonas, pseudomonas. Oh my God, pseudomonas, pseudomonas where more often in diabetic patient, where in the ulcers, could be bed sore ulcer, bed ulcers. We have, for example, on the distal portion of the lower extremities, because diabetic patient lose sensitivity with the time, and they can hurt himself without even notice it, and also come up. And because of the lack of oxygenation, because of that is the nature of the diabetic patient, they cannot have enough oxygen in the distal portion of the extremities. They are going to be populated by this guy Pseudomonas. This is very difficult to treat. Beta-lactamase resistance, beta-lactamase resistance. So these are the big guns. These are the big guns. These guys are going to, is the bacteria is going to produce the beta-lactamase, this oxacillin, methicillin, nafcillin, carbapenem, they are going to just kill it. The bacteria is gone. All right, so penicillin. Okay. Okay, methicillin was one of the first, the methicillin, as you know, is coming from a fungus, right? In the nature, they found the fungus, and from there, they isolate the methicillin, sorry. So methicillin is M, and this methicillin was working nicely in the 60s, in the 50s, but what happened in the 60s appeared one Staphylococcus aureus, Staphylococcus aureus, that start to be resistant to this methicillin. And that's where is coming the word resistance, MRSA. We have MRSA, methicillin resistant Staphylococcus aureus. So now we have MRSA. MRSA is actually the name for Staphylococcus, especially Staphylococcus. We have some Streptococcus too, Streptococcus. but mostly are Staphylococcus. They have high capacity to mutate and produce resistance. Okay. All right. So that is about. So let's talk about the cephalosporins. What is the first question that we are going to see is what spectrum it is, and the spectrum is here. Remember, we have first generation, second generation, third generation, fourth generation, fifth generation. I want you to know at this moment for 1, 2, and 3 generation and the fourth generation. Number one is mostly for positive. Positive. So please, if you have a bacteria that is gram-positive, you're not going to give second generation. Why? Because second generation for positive and negative. So be careful. You don't want to kill you don't want to kill the flora. No kill flora, please. And how we kill the flora? With broad spectrum. Broad spectrum. And who has broad spectrum? So far we already talked about penicillins, okay, tetracyclines. Now we are talking about cephalosporins and macrolides. So those are actually broad spectrum. What they are going to do, and listen very clear, open eyes, open ear, please. Flora, when this destroy, you destroy the bacteria who produce vitamin K. So any broad spectrum, and that's why it's important to know what is the spectrum. Any broad spectrum are going to sweep out the flora, killing the flora, the bacteria, and what's happening with the production of vitamin K is going down. So as a consequence, what is going to happen? Bruises. The patient have bruises. Bleeding. So you need to check for bleeding and bruises. So be careful with that, okay? And besides that, of course, they're going to have the proliferation of C. diff, the C. diff. And open eyes, open ears, again, C. diff is characterized because the description of the diarrhea is a watery diarrhea, watery diarrhea, watery diarrhea. Okay? All right, perfect. All right, so first generation, gram-positive. Second generation, positive and negative. Third generation, positive, negative, and negative. And the broad spectrum is the four is equal. Positive, 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 negative, negative are the fourth generation. Okay. Fifth generation is going to be used for MRSA. All right. So here we have that electrolyte imbalance that is going to be hyperkalemia, hypernatremia, similar as the penicillins. Okay, remember that there are penicillins and cephalosporins are cousins, so that's why here penicillin from 100 people who are allergic to penicillins, 10 of them are going to be allergic to cephalosporins. So if you have allergies to penicillin, don't try to give penicillins, or you need to question the prescription if they give cephalosporin. So what they are going to give, the second line, and who is the second line? The macrolides, the macrolides, the macrolides. If you have a patient who are suspicious of she thinks they have some allergy, you need to ask directly what was happening after you take penicillin the last time. So you need to say the penicillin as name. So don't say antibiotic because it could be what other antibiotic. You need to check directly the name of penicillin. Okay? Ask to the patient in that way. Okay, so here we have cephalosporins. They are going to electrolyte imbalance, and as any other antibiotic is going to be nauseous, vomiting, and most commonly cephalosporin produce diarrhea. Antifolates. What are antifolates? Antifolates, if you see here, we have one. We already talked about what? The aminoglucosides, tetracycline, and macrolides. Here in beta-lactam, we have penicillin, and we have what? Cephalosporin. Okay? And now the last one. So we have 1, 2, 3, 4, 5 group of antibiotics. The nucleic acid inhibitors are going to be the antifolates, that are the sulfas, and the quinolones. It can be called the fluoroquinolones. fluoroquinolones or quinolones are the same. So let's start. We have the sulfas listen S, right? S is having sulfur in that medication. So what is the number one antibiotic who produce allergies? Penicillin. Number two, cephalosporins. Number three, you guess what? Sulfas. Okay, sulfas. So sulfas is called sulfas because S have a sulfur in the her structure. Okay. All right. So here we have if there is they are going to have is allergic to sulfonylurea. So you are not really in that moment yet, but this is an oral anti-diabetic medication. Who's taking this? The diabetic patients for decrease the glucose in blood. But this is have sulfonylurea. This medication has sulfur, similar as the sulfa. So if the but it's not antibiotic, please. Sulfonylurea is going to decrease the amount of glucose in blood in diabetic. When it's the time, you will learn about this. But if you're allergic to sulfonylureas, probably you're allergic to sulfas. Okay, probably you're allergic to sulfas because they have that sulfur in the molecule. Thiazides, you're familiar with thiazides, are diuretics. If they are diuretics, this guy has sulfur 2 in his component. If you are allergic to sulfa, you can be allergic to thiazides. So be careful with that. All right, so diabetes and thiazides. Okay. The same thing for salicylates. If you're allergic to salicylates, there's a sulfasalazine that is a bacteriostatic for skin problems. So we are going to see another time that. And we are going to see the how coumadin is going to increase in action. So one thing I want to tell you, sulfas, before I forgot, what is sulfas? It's broad spectrum, okay? Now, talking about the broad spectrum, all antibiotics, okay? So they are going to kill mostly the flora. We got that? Flora, okay? Flora is dead. Now, what happened? You start to bleed and you have to, you have some, for example, bruises, right? Or bruises all over the body. Now, what happened? When you have the flora down, you have low vitamin K. We got it? We repeat that in the previous hour, right? But now, let's go beyond that. Vitamin K is low. Now, this patient, for whatever reason, is receiving coumadin, right? So if you remember cow, coumadin, warfarin is the same. And kept the cow, K is competing with the vitamin A, and you check with the PT, right? That is less than 15 seconds. So they are going to compete with the vitamin K. So if you have broad spectrum, that is going to decrease the vitamin K. If you, in addition to that, the patient is receiving coumadin, the effect of the coumadin is going to increase. Why? Because coumadin, what is doing? Coumadin or warfarin is competing with the vitamin K. And if you are receiving broad spectrum and you're killing all the bacteria, you have low vitamin K, so it's going to make it worse. So the effect of the coumadin is going to increase. Open eyes, open ears on that. All right, so the fluoroquinolones. The fluoroquinolones are going to be a very potent antibiotic. They are going to be used for gram-positive and gram-negative. Okay, but mostly we are going to use for pseudomonas. This is a big problem. Pseudomonas, very common to see in diabetic patients, diabetic mellitus. Okay. So not too much food, again, not too much food. When that means not too much food, if you take with food, tetracyclines, they are going to decrease absorption. If you take with food, the macrolides, they are going to decrease absorption. If you take with food, the fluoroquinolones, they are going to decrease the absorption of the antibiotic, of course, right? Okay, so here one thing, well, I'm going to just mention something at the end. Quinolones. Quinolones, we have actually the nephrotoxicity, hepatotoxicity, and that is high yield for NCLEX. Should be not prescribed in patients less than 18 years old or more than 60. No less than 18, no more than 60. No less than 18, no more than 60. No less than 18, no more than 60, okay? All right, so that is what is going to do. So we already see that there is higher incidence for muscular skeletal disorders, tendon rupture, okay? Tendon rupture. Okay. Names here, very common is the norfloxacin, ciprofloxacin, levofloxacin. Levofloxacin, okay, is the levaquin. All right, so we are going to finish with the vancomycin, and we are going to go back to the metronidazole just a little bit. Vancomycin looks like it's aminoglucoside, but far away from the truth. So vancomycin is not an aminoglucoside. They have even some similar side effects, but they are not going to be aminoglucoside. It's separate apart. So that's why we finished the antibiotics already. This is other groups, others. Let's put it others. And this is antibiotic that is going to have similar mechanisms as the side effect of the genta, but similar structure of the beta-lactams. So it's kind of a combination. So that is totally apart antibiotic. So what they are doing is gram-positive. So remember, gentamicin, aminoglucoside, gram-negative, but this vancomycin is for gram-positive. Gram-positive, please. And MRSA, okay? They are going to be the first drug to choice when you have Clostridium difficile. When you have Clostridium difficile. When you have Clostridium difficile, they are going to, you have this watery diarrhea, remember? Watery diarrhea, okay? And they are going to have one side effect, that is the red man syndrome. There is other antibiotics that produce red man syndrome, so this is not the only one. So the most common is going to be vancomycin, and what happened and when is going to happen? Is the patient, you ask yourself, is going to die or not? Okay, so red man syndrome, you start to give the medication too fast. It means too fast that you are giving you're giving less than 60 minutes all the solution, all the medication dose. So that is going to be considered fast. And if you do that, the patient after 4 to 10 minutes are going to produce this erythematous or redness of the neck and face, okay, and part of the thorax. So mostly is the upper part of the body who is going to be affected. All right, so I'm red, so what, right? So what happened is that redness is because you have release of histamine. What is the cause of that? We don't know. It's idiopathic, elegant way, right? Idiopathic, idiopathic, okay? Idiopathic. So we don't know the reason. But what we know is that they release histamine. If you have too much histamine, what is going to do the histamine? The vessels are going to vasodilate. But if you have too much histamine, you're going to have actually hypovolemic shock. No, you're going to have this, that the perfusion of the brain and rest of the body is not going to arrive to the organs. So antihistaminic in excess can produce the death of the patient, especially if the patient has some already cardiovascular problems, like previous myocardial infarctions or arrhythmias. They actually can produce the death of the patient. So what is the treatment? The treatment is going to be diphenhydramine, is the Benadryl, okay? And that is, if there are some cases they can give it antihistaminics before the administration. Actually, that is wiser too, to give antihistaminic before to give vancomycin. Okay, vancomycin, they have several side effects besides the rash. What we need to pay attention in the vancomycin red man syndrome is the hypotension. That is what can give us a problem. If you have hypotension, what to do? If you have hypotension, most likely the doctor is going to increase fluids in IV to reestablish the blood pressure again. Okay. All right. And you as a nurse, you're going to give the antihistaminic. Okay. So one thing I want to review here is the vancomycin. Please open eyes, open ears. Vancomycin. The therapeutic range in blood is going to be 10 to 20 micrograms per ml. Okay, and that is going to be used. Vancomycin, please, is number 1 for MRSA. All right, so we are going number 2 for C. diff. And remember, you need to give the medication in more than 60 minutes IV. More than 60 minutes. That is the way it should be. More than 60 minutes. Otherwise, if you give less than 60 minutes, you are going to have a red man syndrome. Okay? Remember, here in this chart, just to finish here, oh, by the way, so vancomycin, when you have C. diff, the other alternative medication is going to be the metronidazole. Metronidazole is antiprotozoal, and they have actually some effect in bacteria too, bactericidal and protozoal. So when you have C. diff, right? So that is going to be vancomycin or metronidazole, plus another medications that we are going to discuss another time. Okay, so here we have a summary here. One thing I want you to remember is this, just to finish this. We have, when you have a patient who need to have some culture, blood culture, and you need to give the medication, please don't give the medication before taking the sample for the culture. Why? Because if you give the medication before the culture, so the culture, what is for? Is to confirm the diagnosis, to know what bacteria we are facing to, right? If you give the antibiotic is going to start killing the bacteria in the patient, and at the time you take the culture, probably you are not going to have bacteria in there. So it's going to be negative. It's going to be really, really messy. So please always do, first of all, the culture, the blood culture, the samples of the lesions, secretions, or wounds, whatever they ask you, and then after that, give the medication, antibiotic. All right, so here we have, I make a summary for you. Here we have the spectrum. The spectrum, we have penicillin, quinolones, cephalosporins, aminoglucosides, vancomycins, macrolides, tetracycline, and sulfur, right? So sounds familiar, right? So we have broad spectrum penicillin, quinolone, broad spectrum. We have broad spectrum, macrolides, tetracycline broad, sulfur broad spectrum. The one who is totally for negative is going to be use the aminoglucosides. The other one is the vancomycin is positive, just for positive. Okay, positive. Cephalosporins, we have first, second, third, and fourth generation. First generation is for positive. You see that? Second generation, positive and negative. Third generation, positive, negative, and negative. So it's a little bit wider for negative in the third generation. Fourth generation is the broad spectrum. All right. Nephrotoxicity. We have penicillin. We have cephalosporins. We have the quinolones, aminoglucosides, and vancomycin. Okay. Aminoglucosides and vancomycin are going to be nephrotoxic. The penicillin and cephalosporin are going to be nephrotoxic. Okay, hyperkalemia, remember? Hypernatremia can lead in problems in the kidney. Quinolones. Quinolones can do the same, nephrotoxicity. So we have the two friends, penicillin and cephalosporin. The two similar half-half is the aminoglucoside vancomycin and the quinolones, that is the fluoroquinolone, in other words, the same, are going to be nephrotoxic. Other things that we have, the ototoxicity. Ototoxicity, we was talking about the aminoglucosides, right? But the vancomycin is going to be ototoxic too. From all these medications, these two are going to be having ototoxicity. Another thing, photosensitivity. Photosensitivity is going to be not too much sun, as we already saw. GI upset, you need to remember that if you take it with food, they are not going to be absorbed. So you need to take it with empty stomach, right? And that produce what? That produce GI upset. So what you need to do is to drink with at least a full glass of water. Is that going to resolve the problem? No, but it's going to minimize the effect. So if you cannot control something, try to minimize. All right, electrolyte imbalance, we have penicillin and cephalosporin, period. That's it. And if you see here, the medication should be given in empty stomach 1 hour after, 1 hour, 2 hours, 1 hour before, 2 hours after, are going to be all of them. Aminoglucosides, no. Why? Because there is no PO. There is no PO in everything is intramuscular or IV. And the vancomycin, vanco or without food, with or without food, right? So it doesn't matter what with food or without food, the vancomycin. All right, so that is about, one thing, please, the magic tools. So please, as we already mentioned in class, so this moment you should know the digitals. More than 2 nanograms is going to be toxic. You need to know the theophylline, that is the methylxanthine, produce bronchodilation, right? And it's going to given in patients with when the other medication bronchodilators are not working. And the main side effect is what? Is the tachycardia. Tachycardia, and the patient is going to tell you that they have palpitations, right? Palpitations. And don't smoke. If you use theophylline, tachycardia, palpitations is the main side effect, main side effect of theophylline. If you smoke, the effectiveness of the theophylline is going down. So you need to take more theophylline, you got more tachycardia. Okay? So what is the toxic levels? 20 or more. Vancomycin, 10 to 20, 10 to 20. So that is called the magic tools, right? Theophylline and vancomycin, the same number, 20, 20, 20, 20, 20, 20. All right? All right. So I think we was covering as very brief summary of the antibiotics, and I want to finish just saying that antibiotics are going to be administered for a specific. So we want to know the specific bacteria. It's better because otherwise, if we do broad spectrum, we have the risk to have some C. diff. Okay, C. diff. So watery diarrhea. Okay, so the medication, you need to wait at least 3 days to make effect. In 3 days, the medication is not making effect, we need to call the provider, because the provider probably is going to increase the dose, review what is the dose, review the increase the dose, or change medication, but not before 3 days. Why? Because the medication that we take every 6 hours, every 8 hours, or every 12 hours, or once a day, that is going to have maximum serum levels of the antibiotic at the third day. All right, so thank you so much. I will post this in the Google, and I hope this could help you a little bit. Thank you so much. Bye.